name's Todd Stivland. I'm a family physician. I started doing home visits in part of my practice about 15 years ago, and I became so busy and so overwhelmed by the amount of need there was in the community for home visits. I actually left the clinical practice and founded Bluestone Physician Services. Initially it was me and with the help of my wife working out of our dining room with a laptop and a rudimentary EHR and an old Honda going door to door. And since then, we've built it into one of the largest assisted living practices in the country. So we service about 20,000 people in 700 assisted livings and group homes. We also have about 4,000 people who are in the community that we provide services for, and operate in Minnesota, Florida, and Wisconsin. Yeah, one of the turning points in my career was the day an elderly woman was dropped off at the clinic. She had advanced dementia. She was living in a new assisted living that was down the street from our clinic. She had an appointment, but we had no records on her. We had no medication list. We had no problem list, no reason for her visit, and she couldn't really give us any information. The only thing we had was a note pinned to her lapel that said, "Call this number for the cab to come get her when you're done with her." There's no way to practice medicine. And I didn't really know what assisted living was at the time. So we started investigating a little bit more. Where was this person living? What kind of care? I went and visited with the nurse at the assisted living, realized that this was the new form of a senior care and growing very rapidly. So after talking to the nurse, I looked at her and said, there's no way you can get these people over to the clinic and provide good care. They have home care, they have hospice care, they have the nursing care at the facility, all there. But we needed to write the orders, and we weren't part of that team. So I looked at her and I said, you're just down the street. I drive by on my way home. How about if I stop in and see people when you need it instead of you trying to get them to the clinic? And that was the start of it, and it worked so much better for me and the nurses and the care team, and certainly the patients and family. So that was kind of my blue chair moment when it says, well, why do I have to stay in the ivory tower? It doesn't hurt for me to step out. Everybody else is doing it. That whole care team was outside my clinic. I need to integrate with what they were doing, not make them integrate into what I was doing. I learned this from our chief clinical officer, Sarah Keenan, who's a fantastic nurse and director, and she came out of the care coordination system in Minnesota, working with our dual eligible. And when working with her, I realized that in traditional medicine, it starts with the physician and then comes down. And so we evaluate the patient and decide what do they need. And then we go and say, okay, you need home care, you need hospice, you need these treatments, you need this testing. In chronic disease management, we have that upside down. We know what the diagnoses are. Most of the time, we have pretty good treatment plans. What we need is to increase the bottom part of that pyramid. Who's out there evaluating the patient and making sure they have access to what they need? As a physician, I'm not very good at that. So with the social workers, the nursing staff, the care navigator staff, who really know the systems and can walk people through that, that's what we need. Unfortunately, right now, we're paid to have a licensed provider go out and see them. That often isn't what they really need. They may need access to us, but they really need somebody to help them get their medications, figure out how to get transportation, get a bed moved from one part of the house to the other part of the house because they can't get up the steps anymore. Those are all things that become much bigger barriers than what drug they're on or what diagnosis I come up with. And so we really need to look at that part of it. We'll need to expand the provider staff, obviously, but we really need to focus on that root group of people that's really the fabric of the care we need in the community, and come up with a payment model that allows them to do their work and be reimbursed for it. Because right now, a lot of systems, there's no reimbursement for that work. We have a medical system from the payment structure to how the insurance is written to how we regulate documentation that's based on acute care. And so if you think about how medicine is taught and how it's paid for and how it's regulated, it's someone comes in with a group of symptoms, we evaluate those symptoms, we diagnose them, and we come up with a treatment plan. That works fine if you're coming in with a new diagnosis. It works fine if you're healthy and now you got sick. It doesn't work fine if you are diagnosed already with 8 chronic conditions, which is average for our patients. 8. We already know the diagnosis. We know the symptoms. What is happening with the progress? How do we do a longitudinal-based, chronic care-based healthcare system? And right now, we're seeing some change in the policy levels, but that's what we need to push and say, we are not taking care of people well because we're doing it with episodic acute care models. And we have to change that to a longitudinal care-based model. We've done that in other areas. We do it with well-child exams. We do it with OB prenatal care. We need to take those same philosophies and say, all right, in the first 2 years of life, we bring those babies in and we watch them and we know what to look for, and we know what to measure, and we know when they're at risk, and then we implement treatment plans. We need to take that same philosophy and put it on the other end of life and say, when are we going to run into problems? What social markers, what functional status markers, what other situational changes are putting people at risk so we can bring the support in before there's acute episode? Think about all the effort we put into post-acute care. Well, post-acute means something bad already happened. We need to focus on pre-acute to avoid that acute episode. And that's where we've got to collect the data and look at it. Right now, we're doing everything off claims data. What diagnosis did you have back here? Now I'm going to go ahead and say, oh, well, you must have been sick. No, you're going to be sick, and we can do that. We have the tools, but we have to implement that in how we document, how we reimburse, and how we schedule these patients for care. And then we can really start making some changes, get the data that we need to know who needs the most care when, and not wait till it happens, and then chase our tail and for 30 days after the hospitalization. Well, with the EHRs now, we can collect it. We're collecting it on the annual wellness exam. We're doing a pretty good job of getting annual wellness exams now. We weren't 5 years ago. Now, most people are getting annual wellness exams in our experience. We can use that tool to collect the data and be proactive on it. But the EHRs aren't set up to do it. The policy isn't set up to do it. But those are cost-neutral changes that can make a big difference in how we move forward.